right? Okay. Good morning, good afternoon, and good evening to all of you. Today we have a very interesting webinar with excellent panelists and exceptional speaker. We don't want to waste any more time. I give the floor to the president of IFSO for a few words of welcome. Dr. Estuardo Berens from Guatemala, please.
Good morning, everyone. Here is morning. From some of you, it's evening, afternoon. Welcome to this IFSO webinar. This is the time of IFSO. It is the turn to IFSO to give this wonderful talk to you. So I just want to give you a warm welcome to the world. God bless you all. Pedrito, go ahead. It's your time. Thank you very much, everyone, for accepting our invitation. God bless you all who will be here.
Thank you, Estuardo. Now I present to you our speaker, Dr. Ricardo Cohen, who is the program director at the Center for the Treatment of Obesity and Diabetes, Osvaldo Cruz, German Hospital, Sao Paulo, Brazil. IFSO past president, IFSO World Congress president at Rio in 2016. Please, Dr. Ricardo Cohen.
Thank you very much, Estuardo, Pedro, and all the panelists here. Let me share the screen. I'm honored to speak on behalf of the IFSO Latin American chapter in this IFSO Global webinar. And we'll talk about on the data-driven type 2 diabetes patients, if any kind and any subtype of diabetes can predict the outcomes of metabolic surgery. Those are my disclosures related to this presentation. We all know that diabetes is a disease continuum where the clinical manifestation is hyperglycemia with a decrease of beta cell function and increase of insulin resistance and adiposopathy. So the fat deposition makes much more sense in predicting the evolution of diabetes rather than BMI itself alone. And we know as well that this disease continuum can be disrupted, and I mean by disruption, the decrease or avoiding micro and macrovascular complications. Thus, over 15 of total body weight loss can do a good job in disrupting the disease continuum of type 2 diabetes. What is the weight of weight loss? If we look at this lifestyle intervention trial, the DIRECT trial, if patients, the mean weight in kilograms in the DIRECT trial was around 100 kilograms. So in the patients who achieve over 15% of total body weight loss, although not pretty common, 2 out of 10 of those patients achieve type 2 diabetes remission measured as A1C below 6.5% without medication. So lifestyle can be a good tool. However, it doesn't work for all patients and probably is not long-lasting. However, it's a good intervention, and the DIRECT trial showed that yes, over 15 of total body weight loss can promote diabetes remission. And if you look at other options to treat diabetes, so as the new drugs are coming out in a few months, like tirzepatide was approved 2 days ago for diabetes by the FDA. And if you look at surgery here, this is a summary of the randomized controlled trials with over 2 years of follow-up that compared surgery versus the best medical treatment. And if you look at the two columns on the right side of your screen, you'll see that patients who reached the better glycemic targets were those who lost more weight. So actually, again, it's another proof that the greater weight loss achieves the better outcomes. However, we should not forget that metabolic surgery, mainly those operations that reroute the food through the GI tract, can have weight-independent anti-diabetes mechanisms that are summarized here. I won't go into details because it's not the focus of this talk, but all of these weight-independent anti-diabetes mechanisms decrease food intake, improves beta cell function, and improves insulin sensitivity. Are there predictive scores that may tell the doctors and patients that the operation will achieve glucocentric outcomes? Yes, we have here the DIARAM predictive score, which was a retrospective study mostly of them, of all of them, underwent Roux-en-Y gastric bypass. And what they did is to stratify patients according to age, A1C at the time of the operations, the use of SUs or insulin sensitizing agents other than insulin, and the use of insulin. And what they found here after doing the scores, the lower scores, the higher the chance of remission. What they found is that in patients that had a lower score, so they were younger, no non-glucotoxicity around the operation, and didn't use insulin, they were more prone to diabetes glucocentric remission. A couple of years later, they incorporated the duration of diabetes, and they improved the accuracy of type 2 diabetes remission based on this score. Another score, the diabetes score, just compare not only the bypass, but the sleeve gastrectomy as well. So the outcomes of using the diabetes score is just the same as the diagram. The diagram, even the diagram 2, they did not correlate weight loss with diabetes remission long-term. However, the diabetes score, yes, they correlated weight loss as a good predictor tool for diabetes remission. So we wanted to move a little bit, a small step towards precision medicine and type 2 diabetes treatments. This was published about 4 years ago by a Scandinavian group where they divided patients with type 2 diabetes into different 6 clusters. The clusters were based in the positive antibodies for autoimmune diabetes, the age at diagnosis, BMI, HbA1c, HOMA-beta, and HOMA-IR. And they divided those patients into 5 groups: the severe autoimmune diabetes, the severe insulin deficient diabetes, SIDD, the severe insulin resistant diabetes, SIRD, the mild obesity related diabetes, and the mild age related diabetes. Those different clusters of patients with diabetes had different clinical manifestations, different disease progression, and probably different therapeutic options. We want to focus in the insulin-resistant patients. Why? Because those patients carry a higher risk of cardiovascular events, regardless of baseline BMI. They have a higher risk for diabetes, kidney disease, and they have a higher risk of cancer. So we did, in collaboration with François Patou from Lille Group, we had 2 independent cohorts, one in France, the other in Brazil, 368 patients in the French cohort, mostly Roux-en-Y gastric bypass in the left side of the screen. And we have 121 Brazilian patients cohort, 100% of them submitted to Roux-en-Y gastric bypass. This rater table shows us that the main characteristics across the cluster into the 2 groups, the ABOS, that's the French one, and the São Paulo cohort, they were very similar. And if we look at the distribution of patients with insulin resistance and the obesity-associated diabetes and the severe insulin deficient diabetes, we can see here that the clusters are basically similar in demographics, in number of patients divided into the 5 clusters. At baseline, the insulin-resistant patients showed a lower insulin sensitivity level measured by the Matsuda index, which is a mathematical formula to calculate the insulin sensitivity. The insulin-resistant patients had a higher stimulated insulin secreted in relation to plasma glucose when compared to the moderate diabetes related to obesity and the severe insulin-deficient diabetes. And the beta cell function measured by the oral disposition index was similar between the insulin-resistant and the obese-associated diabetes. So those are the baseline characteristics. The outcomes were the type 2 diabetes control, the glucocentric control first at 1 year in the absence of any glucose lowering medication for at least 1 month. And those are the criteria for defining partial and complete remission. Regarding kidney outcomes, we divided the patients into 3 categories based on the estimated glomerular filtration rate calculated by the MDRD formula. What we wanted to look was the association between the post-op type 2 diabetes remission, the glucocentric remission, and eGFR increase and those clusters. We observed glycemic benefits and weight loss in the 3 clusters. However, type 2 diabetes remission at 1 year was higher, significantly higher in the insulin-resistant patients when compared to the insulin-resistant patients. We compare to the obesity-related and the severe insulin-deficient patients. The patients with insulin-resistant achieved in both cohorts, the French and the Brazilian cohort, achieved a higher rate of type 2 diabetes remission. We try to correlate with the clusters and the predictive scores. And what we saw that except the ABCD score, clustering compared to the predictive scores were very accurate. Both the cluster classification and the predictive score were very accurate, both comparable in forecasting type 2 diabetes remission. And if you look at the difference in the operations, again, the Renal gastric bypass had better type 2 diabetes remission in all clusters: the insulin resistance, the moderate diabetes related to obesity, and the insulin deficient patients compared to the sleeve gastrectomy. If you look at the eGFR at baseline, severe insulin resistant patients had, we can see here in the table, a decreased eGFR at baseline. And if you look at the post-op analysis, we can see this is the illustration of both cohorts reunited. You can see here that we had a marked post-op reduction of CKD stages in patients with severe insulin resistance when compared to the obesity-related diabetes and the severe insulin-deficient diabetes. So there's a significant greater CKD remission in severe insulin-resistant patients. This is a very interesting finding. And if you look at eGFR, we can show here improvements of eGFR in patients with severe insulin resistance when compared to the other two clusters. However, there's a drawback here. eGFR is based on serum creatinine, and those patients, they decrease their lean mass after the operation, and maybe there's a contamination quote of the eGFR in those patients. However, I can tell you that the three clusters lost the same amount of weight during the 1-year follow-up. Thus, we can see here that this improvement in patients that lost the same amount of weight, we can consider eGFR at least a good comparator marker of improved kidney function. The odds of renal improvement were not significant in the patients identified as good glucocentric responder of each score that we compared to. So regarding kidney function, the scores do not correlate glycemic control with improvement or worsening of kidney function. And as I told you, look at the left side of your screen. Weight loss measured by total body weight, percent of total body weight here, was similar. There's no statistical significance between the three groups. That's why eGFR can be considered as a good marker in the three clusters, exactly because they lost roughly the same amount of weight. So the beneficial outcomes in the patients with severe insulin resistance were observed without any difference in weight loss. Probably, we can see here the right side of the screen, there are the weight loss independent mechanisms involved, like the incretin secretion, the difference in bile acid secretion as well, the uptake of glucose, enhanced glucose uptake in the peripheral muscle, decrease of gluconeogenesis based on insulin sensitizing mechanisms in the bowel. So yes, weight loss is important, but we have behind the surgical intervention, mainly the Renal gastric bypass, some very interesting mechanisms of diabetes remission. What about safety? We had no deaths in the three clusters analyzed, and 6% of minor complications among each clusters in the two groups, the French and the Brazilian. It was interesting. There's 6% in both cohorts. So what is going on in the pathophysiology of patients with severe insulin-resistant diabetes? Patients had a higher fasting level of plasma insulin, or C-peptide, that's a specular secretion of insulin from the pancreas at baseline, with the severe insulin-resistant patients compared with the obese-related diabetes and the insulin-deficient diabetes. We can see here at the table that fasting insulin is significantly higher in the patients with severe insulin-resistant diabetes. And it's interesting to see that blood glucose values did not significantly differ among the three groups, in spite of a higher fasting insulin measured in the severe insulin-resistant patients. we can see here very interestingly that insulin levels decrease in all clusters. However, the decrease of insulin levels was greater in the patients submitted to the operation that were severe insulin resistant. So there is an association of glucose and kidney improvements with the decreased insulin levels. And then based on what Nolan and Porris just provoked us with a theory on the pathophysiology of diabetes in severe insulin resistant patients, we know that food plus gut response can overstimulate the beta cells without changing blood glucose. And that the stimulus of food is required to stimulate the beta cells to secrete insulin. So the hyperresponsiveness of beta cells leads to hyperinsulinemia that promotes, as a collateral effect, fat deposition, so the adiposopathy and inflammation. And inflammation plus the ectopic fat distribution leads to dyslipidemia, macro and microvascular damage, and all the consequences like renal failure, blindness, stroke, myocardial infarction, and etc. So that's why probably insulin-resistant patients, they carry long-term increased cardiovascular events and renal problems. And we try to design a tentative explanation for that. The Roux-en-Y gastric bypass here decreases food intake and prevents the contact of food. And then there's through neural connections from and to the neuroendocrine cells with a decreased food intake may improve the beta cell sensitivity, leading to decreased insulin levels. So this is exactly the opposite that normally we always thought about the pathophysiology of diabetes in some patients. Finally, data-driven type 2 diabetes patients clusters, yes, they can predict metabolic surgery outcomes. The severe insulin-resistant diabetic patients have excellent outcomes after metabolic surgery, both in terms of type 2 diabetes remission, glucocentric remission, and renal function. There is no additional surgical risk in patients with CKD and metabolic surgery. We showed this in our randomized control trial published a couple of years ago, where patients with CKD do not carry higher risks of operative complications. And I understand that, and we understand that that's a step towards the understanding of type 2 diabetes pathophysiology, and a first small step to understand and to utilize precision medicine and type 2 diabetes treatment. Thank you very much.
Thank you, Ricardo. Thank you very much. Outstanding presentation, as always. Now, I want to introduce you our panelist, Alex Mira, who will give us some comments about the presentation. Alex Mira is currently a senior clinical lecturer and consultant in endocrinology at Imperial College London, and interested in the mechanism through which lifestyle intervention, pharmacology, bariatric surgery, and medical device improve weight, metabolic control, and diabetes-related microvascular complications. Dr. Alex.
Thank you so much for asking me to comment on this, Ricardo. I don't think I have seen such amazing data in a very long time, so congratulations. Two questions I wanted to ask. The first one is a very clinical one, and I mean, people have done other types of phenotyping studies that involve kind of metabolomics and all sorts of different things that are very difficult to use in clinical practice. Whereas what you have done is that you have used some pretty simple measures in order to classify those patients, nothing particularly fancy. So what I wanted to ask you is, how do your findings change our clinical practice? So how does the concept of insulin resistance comes into the existing predictive scores, and in terms of how to choose and prioritize patients? And the second question is, what is the next step in terms of validation of your findings? Do they need validation? And what do they mean in terms of the next studies that we need to do?
Thanks, Alex, for your comments. The first question is interesting. Yes, the clustering that was developed by the Scandinavian group was very easy to accomplish clinically in our retrospective cohort. So what I think is that you clinicians do not have so far very good insulin sensitizing drugs other than metformin and pioglitazone. You have good tools now with semaglutide 2.4 milligrams and the next tirzepatide that promote weight loss and probably will lead to decreased insulin resistance while patients are taking the drugs. So what I think is, I honestly think that in the very near future, patients with lower BMIs that are insulin resistant, they will pass through the first step with the potent medications that is out in the market in a few months. And when we'll have patients that do not respond to the best medical treatment and they are still insulin resistant for some reason, then surgery will be applied. So what I think is that surgery won't be the main actor in treating patients with lower BMI, or if they have other complications like, well, gastroesophageal reflux or joint problems because of weight, of sleep apnea, maybe surgery will be more effective, maybe, depending on the weight loss long term. As we know, tirzepatide carries 70% of patients with over 25% of 25% of total body weight loss. So 20% of total body weight loss. So it's a very good drug. So I think surgery will be the rescue therapy for those patients with insulin resistance who do not achieve good outcomes with the new treatment regimens. And the second question,
the second question is, what is the next step? So you've done a great start. Do you need to validate your findings? Can you validate them from the available RCTs in the field?
I think we would like to carry an RCT where we randomize patients with insulin resistance. I think there are 3-arm: insulin resistant and obesity associated diabetes. And we would treat the first arm with the best medical treatment available, the other one with surgery, and the third one we would compare with the patients without insulin resistance. We need a validation because this is a retrospective study. So although the findings are very nice, I think we need validation with an RCT. And I think you agree with that.
Can you not use the already existing RCTs to validate your findings?
I don't know if we can use this. For example, some of the RCTs, I know that the Elephant Goldfind RCT, where Anita Krokos was involved, they did not measure fasting insulin levels. So probably we're going to have some studies who did not measure insulin levels at baseline. So we won't know exactly if they were insulin resistant or not. In our trial, the MOMS trial, yes, we do have the measurements, and some of the patients in our cohort are the MOMS patients. So we use some data. I spoke with Phil. Phil has some among his 150 cases in the Stampede trial, they measure in some patients, the other not. So I don't know if we could have this. I suggested to David Cummings, who's running the ARMS T2D, their consortium, to look at the data, and he said they will look for this. So I think maybe your question will be yes, but I'd like to carry an RCT with patients with insulin resistance, with the medical treatment, the modern one versus surgery versus the comparator will be the obesity-associated diabetes.
Thank you.
Excellent, excellent. And now Teresa Pretty, she is endocrinologist of the Center of Obesity and Diabetes of Osvaldo Cruz, German Hospital, Sao Paulo. Please, Teresa.
Hi all, it's a pleasure to be here with you today. I don't have a question, just a comment. The most interesting finding of the study is that for the first time we have proved that patients with severe insulin resistance have better outcomes after metabolic surgery. We used to know that in our practice, but we didn't prove it until now. It's a retrospective study. We need more, but it's a great finding. And I think that this will impact the choice of treatment of patients with type 2 diabetes and the decision of indicating metabolic surgery earlier for some patients, especially that with diabetic chronic disease. What do you think, Ricardo?
As I gave the first answer to Alex, I although I'm enthusiastic, and actually I was the first one who did a metabolic operation back in 2005 for patients without higher BMIs, I don't think that metabolic surgery will be the first option in patients with type 2 diabetes in lower BMIs or patients that do not have other comorbidities linked to obesity. What I think is that we will be the second option when the best medical treatment fails. The new drugs are very potent. We know that, we use them. So I strongly believe that patients, we need more diets that work. We need more direct diet trials that really prove long-term effects, but not isolated with the best. We need an intervention that is physiological with the new drugs and surgery. The more options we have, we will treat much more patients than we're treating right now. And unfortunately, as a surgeon and enthusiastic, this is my big disclosure, I'm in love with metabolic surgery. I think in most of the patients with lower BMIs, and I think BMIs from 30 to 40, I think medicines will be the first options with newer and more potent dietary interventions, and then surgery will be the rescue therapy.
Perfect. Now I want to introduce Dr. Carla Musso. She's a Chief of Diabetes Department at Favaloro Foundation, Vice President of Argentine's Diabetes Society. Please, Carla. You are mute.
Okay, congratulations, Ricardo. It was a great presentation and a great paper. I have the feeling that I found this paper very useful to identify patients who will benefit with metabolic surgery. So in this case, patients with severe insulin-resistant diabetes that have remission of diabetes and improved nephropathy using this classification. So I have the feeling that we have another tool to indicate metabolic surgery. But if we try to explain this finding with the relation with insulin resistance, I believe that insulin resistance is an inflammatory situation with increased levels of cytokines, adipocytokines, and TNF-alpha. So that justifies the increase of the disease as nephropathy. And that reminds me of a paper that I wrote a few years ago when I was working at the NIH, where I work with patients with extreme insulin resistance, like lipodystrophy type A, insulin resistance type B, and they all have nephropathies and diabetes, but the nephropathies are not diabetic nephropathy, are different kinds of nephropathies related probably with insulin resistance. So I believe that your finding is very useful for us and to improve to send patients to metabolic surgery.
Thanks, Carla. Yeah, I agree. No, I agree with Carla, as always.
Okay, perfect. Okay, our last panelist, Jose Rodriguez. He's president of Mexican College of Bariatric Metabolic Surgery with over 30 years of practice. Jose, please.
Hi, everybody. I want to say Ricardo is an excellent work, like always. It's an excellent paper. And just put several steps to work with, new medication plus, and then surgery and etc. Can we introduce in the middle the new treatment plus endoscopic new technique for obesity treatment, like put together on that and working and expect the same results than the surgery itself or the medication itself?
I don't think so, Jose, because endoscopic interventions so far, they are based on restriction. And first, that restriction doesn't last. Second, it does not have any weight independent mechanism. And weight loss, I was in Colombia last week, and weight loss in the MERIT trial, that's a randomized controlled trial with endoscopic gastroplasty, is around 14% at 2 years. And I don't think this will be better than the medications alone. It needs to be tested. But surgery, we can see here that the sleeve gastrectomy, even with the mechanism behind the sleeve gastrectomy, the one-wide gastric bypass was better. So we need both. We need massive weight loss, over 15% at least, and we need weight-independent mechanisms to promote the decrease, as Carla mentioned, decrease of the inflammation markers and avoiding the progress of the disease continuum of diabetes. So I don't believe that right now we have any evidence that back up endoscopic interventions. Maybe in the future, when they improve, when we have double interventions with restriction posts and like an endo barrier or the balloon sleeve that another company called Kieran is developing, maybe we can use them with medications to promote the best outcomes. But currently today, May the 17th, we don't have any evidence to promote any endoscopic interventions regarding metabolic outcomes.
Yes, I made that comment because I've been talking with a lot of guys, and they say with the new medication we got in the market in the future, near future, with the surgery is going to be in the higher BMI, and you're talking the opposite, doing the lower BMI in a special category. You put it over there, and I'm agree with you. But my comment was, let's think that everybody say what's going on that, because I've been hearing a lot about the endoscopic or new device or new products in the surgery, plus the new medication is going to be, the main idea in the future in the type 1 and type 2 obesity.
Jose, I'm not speaking on BMI. I didn't mention BMI at all because we don't, BMI is secondary. So I think that BMI itself, it's not a good thing. It's adiposopathy. The disease of fat ectopic deposition is the problem, regardless of BMI. But you can hear whatever you want. I listen as well. Oh, and the side procedures are here, but where are they? I don't see them. What I see is failures of endoscopic gastroplasty. I see some I'm involved with some different companies that I disclosed in the beginning on combinations of the gut should be involved to promote weight loss independent effects over diabetes. I have no doubt about this, because duodenal switch, stages, gastric bypass, they promote long-term much better metabolic outcomes, including weight loss, than a sleeve gastrectomy that has some mechanisms behind it. So I think, yes, we need to evolve to less invasive therapies, but I think we should be serious. We should go step by step and show data, because opinions are easy to give. Data is very hard to publish.
Yeah, I'm agree with you. Thank you, Ricardo.
Thank you. Thank you.
Great. Okay, any last comment or question for the panelists or chairmans?
Beautiful talk on paper as always, my dear Ricardo. But I have a comment. Why do we have to wait that a patient become a person with diabetes if we know he has insulin resistance? Why don't we intervene these patients before prediabetes or diabetes? Why? I ask that to the clinicians. Why do we have to wait the patient become a diabetic patient? Instead of insulin resistance, we capture the patient with insulin resistance. He has a weight of 300 pounds. Do you think that only 30 pounds less is going to be enough to relieve this patient? Remember the quality of life. Okay, maybe the insulin resistance will be better, but about the weight, about the quality of life. I want to launch this question to all of you. Thank you.
Tarissa, what's your opinion? And one question to Estuardo. Yes. What do you mean by intervention? Surgical always, or medical intervention as well?
Surgical. Of course,
surgical.
The surgery is better than the medical intervention. And you know that, Ricardo.
I don't think if I'm sure I know. With the new drugs, depending on the patients, probably we're going to have the same results. I can tell you that we need to be very careful in now, because the new drugs, semaglutide 2.4 milligrams, the step 1 trial, showed that 35% of the 35% of the patients achieve over 20% of total body weight loss. Tirzepatide achieved 70% of the patients over 20% of total body weight loss. So I think we should be careful with what the way we behave right now. So maybe in this patient, I personally would refer to Teresa and the other endocrinologists at my center to put them under the medical treatment. I mean, it's a physiological intervention as well. But this is my feeling right now. We have no data so far comparing both surgery plus the new drugs.
But do you think that 20% will be enough?
You know, that's a good question. There's a paper published last year in Diabetes Care that showed that the effects of weight loss over type 2 diabetes, glucocentric control, and the decrease of cardiovascular risk factors has no significant difference in losing weight over 20%. 25, 30, 35% has the same effects of 20%.
Okay, but you want to be thin. That's
Yeah.
the thing. That's
you want to
the
be thin,
point
or you don't want to you don't want to die from cardiovascular events. That's the question. You want to be thin, or you want to live even with a BMI of 28 with no. I'm playing the devil advocate. I'm a surgeon, you know that. But what do you want? Avoid dying or undergoing dialysis, or being thin, a Guatemala model?
Okay, Teresa.
Well, I do agree that we now with the new medications, we have to start with them, because some patients will lose weight and be healthy, and we all agree that the medications benefit all some patients, but we have some difficulties in the clinical treatment. We endocrinologists know that patients have some difficulties in the way, like maintenance of the weight, the costs of the medications, and the weight that will make our patients happy, like Estuardo said. So there are very many obstacles in the treatment. And we have to think that we have to keep the weight for a long period, and this is difficult for all the patients. Maybe 5% will keep the weight for long periods. I don't know if we will have patients that keep this kind of medications for all their lives, because the cost is very high. So we have a lot of problems to solve in this way. It's not so simple. And I'm very enthusiastic of surgeries as well, but we have to talk to our patients about all the therapeutic options that we have now, and the patients have to decide with us.
Great. Carla?
Yeah, I agree, of course, with Teresa, but in terms of the cost of medication, we also know that after metabolic surgery, maybe we still need to use very cost medication, so a very high cost medication. So I think the metabolic surgery is one more tool, but we still need to give medication to patients. So that's we need to put this in the balance.
Great.
I think that the more options we have, the better for the patients. Drugs, diet interventions, and surgery. And these should work together.
Exactly. It's a combination, Ricardo, as
Yes.
you usually say. All
I
right.
have a question, Pedro, to Ricardo, about why you measure insulin levels, because we all know that there's a high variability inter and intra-individual patients with the levels of insulin. So it's much better to use C-peptide instead of insulin.
We did both, Carla. We did
Yes,
both.
I know, but
there was a strong correlation between the two tests in our trial, even in our randomized control trial. So That's why we use both. And I agree with you, C-peptide is more accurate than the fasting insulin levels. Agree.
All right. Luis Poggi?
So,
Do you want to comment?
Ricardo, congratulations on the paper. I'm asking about of technique. You design a bypass with 50 centimeters of biliopancreatic limb length. If you change it more or less, do you think that it will be a difference in the results, or it will be the same in front of lose weight and in front of metabolic results? And these changes in front of the mix, the combination, that means surgery plus treatment. What is the answer?
Thank you, Lucho. We don't have the right answer, but I can tell you that we published 15 years ago a paper with BMIs over 50 that had long limbs and shorter limbs in patients with BMI over 50, as I mentioned, and the metabolic outcomes and weight loss was the same at 4 years of follow-up. So, and patients with longer biliopancreatic limbs has greater nutritional issues, diarrhea, etc. It's a pity that Alex has to leave for the other his other lecture, but he published earlier this year when they compare longer limbs and shorter limbs, the endpoint was GLP-1 secretion and glucocentric outcomes, and they were the same, exactly the same. So I really don't think, and another no, we keep metformin in all our patients post-op. Patients with longer biliary limbs and metformin have diarrhea in 80% of the time, and so as the outcomes are the same, GLP-1 secretion is the same, microbiota is the same as well in Alex's paper. So bile acid should be the same as how they did the measure, but probably is. I don't see any evidence right now to enlarge the limb length based on some 1 or 2 or 10 retrospective studies that didn't compare to anything. And I know that Ralph Betterly from Switzerland is running a randomized control trial exactly with answering this question. Longer limbs, better outcomes. Longer limbs, worse nutritional outcomes. We'll have the answer soon. So, but currently we do 50 centimeters biliary limb, 100 centimeters ruling, and in our trial we did this. All the randomized control trials were exactly the same, and the glucocentric outcomes and the decreased long-term cardiovascular events measured by the triple endpoint, control A1C, blood pressure, and cholesterol, were the same. So, Lucho, so far I think we should stay with shorter limbs because we don't have any evidence of longer limbs and good outcomes.
Thank you.
Okay, great. Any other thought, comment? No? Okay.
Yes, Ricardo, do you think that you, with this study, this paper, you open the window to make a prediction after surgery in these 5 types of patients for you?
I didn't understand. Addiction?
Yeah. No, predictions. The predictions.
Yes. Patients with insulin resistance will have better outcomes than patients without insulin resistance. So this is, I know this is conventional wisdom. We all knew in the past that patients that go with higher insulin or C-peptide levels, fasting C-peptide levels, the SLS study showed this back in 2004, where they showed that basal insulin levels predict less cardiovascular events. So they showed this a long time ago. What I think now with this paper and other papers that will come after this, comparing in the randomized control fashions, the different clusters of diabetes, I'm pretty sure that yes, we can predict that patients with insulin resistance will have better outcomes, kidney and glucocentric, than patients obesity-related diabetes or the severe insulin deficient. So I think, yes, Jose, we'll change the way we see patients with metabolic surgery.
Okay, and the other field we are seeing more and more often in the office is the age-related obesity. What do you think of that group? This is really important for us because we're checking out the age of the patient coming to the office is getting older and older and older because the expected life is better. What do you think of this group?
What I think that is we didn't it's not in the main paper, but it's the supplement of this paper. We compare with the age-related diabetes. The problem of patients with age over 70 years old is the amyloid deposition in the pancreas. So whatever we do, probably those patients won't have a good outcome. And if you look at the diagram and the diabetter, they did not predict good outcomes in patients over 70 years old. And actually in the diagram too, where they had the history of diabetes, they predicted over 75, it's worse than the rest. So I think age-related diabetes won't respond. They will respond, but they will respond in a worse fashion than patients with insulin resistance or even with insulin deficient younger patients.
Perfect. Thank you.
We have a paper published like 2 or 3 years ago in patients that they had a bariatric surgery over 65 years, and the results were very good in terms of diabetes and with less insulin need, and also of course they start to walk, and there's a lot of good
other benefits.
Other benefits, yes.
Yeah. So
Okay.
bariatric surgery still have other benefits than diabetes. It improves reflux, it improves mobility. So yes, we should, if you focus on diabetes, probably we won't have good outcome as good as younger patients. But the general improvement of quality of life is remarkable.
Excellent. Okay, we are out of time now. I personally want to thank each of you guys and all the panelists and the participants. And also I want to thank to IFSO for giving us these opportunities. The final word by the Dr. Luis Poggi. He's the next president-elect for IFSO Latin American chapter. Please, Luis.
Okay, thank you, Pedro. I want to thank to Ricardo for this conference, because it's a nice paper and a very important topic, because this is one of the big problems that we are facing all the days in our work. But we need to work and we need to investigate more about that. But we have results very important to begin to make some changes in our work, daily work. So only I need to thank again to the opportunity to IFSO and all the participants in this webinar, and closing with very nice results and very nice participation of all of you. Thank you. Thank you very much.
Thank you. Have a nice day. Bye-bye.
Thank you.